So we've had a very exciting session. Good afternoon, everybody. From Gynae 2, we present an interesting case. I think abnormal uterine bleeding is perhaps the most common symptom with which women come to our OPDs right from menarche to menopause. And so much so that we've got algorithms defined for women right from puberty menorrhagia to perimenopausal bleeding. But this interesting case rather defied the algorithms that we usually make for working out these patients on diagnosis and their management. So to present this interesting case and to tell the story from my unit, we have Dr. Pooja, who will take you through the history, followed by Dr. Saroj, who's an MCH candidate, and Dr. Seema Singhal will give the final comments. So over to Pooja.
Good afternoon, all. My name is Dr. Pooja. I'm junior resident from Obs and Gynae department. To start with the case presentation of today's CCR, Mrs. X, 44-year-old, well-educated lady, resident of Jammu, who was apparently asymptomatic 3 months before when she first developed episode of heavy menstrual bleeding. It was sudden in onset, continuous bleeding, which began 5 days after her usual menstrual cycle. It was heavy flow, soaking 3 to 5 pads per day. It was not preceded by any history of trauma or act of sexual intercourse. There was no history of previous irregular cycles, abdominal pain, dysmenorrhea, no history of bleeding from other mucosal sites, orifices, no history of easy bruising or excessive bleeding during injury or surgery. There was no any history of breathlessness, palpitation, chest pain, no history of epigastric pain, yellowish discoloration of skin or eyes, hematemesis or tarry stools. Coming to the menstrual history, she attended menarche at 13 years of the age. Her cycles were regular, lasting for 4 to 5 days, occurred every monthly with average flow and no history of dysmenorrhea. In her OBS history, she is Paris woman with a single male child who delivered through an uneventful cesarean section and now uses barrier contraceptions habitually. In her past history, she underwent laparoscopic paraovarian cystectomy in 2011, and she is also a known case of Graves' disease since 5 years, which is well controlled on tab neomercazole 5 mg once daily. In her personal history, she is not addicted. She does not suffer from any addiction, graduate, and belongs to upper socioeconomic class. Her family history was not significant for any comorbidities or malignancy. With the above complaint, she first sought treatment from her family physician in Jammu, who informed her that she had cervical fibroid and advised hysterectomy. She took second opinion from her regular physician in Mumbai, who advised her same, at which point patient presented to AIIMS. On presentation, her general condition was fine with ECOG performance score of 0. She was afebrile, no pallor with stable vitals, and her nervous, cardiovascular, and respiratory examination revealed no any significant abnormality. On per abdominal examination, it was abdominopelvic mass rising from pelvis reaching up to umbilicus, corresponding to 20-week size gravid uterus, hard in consistency, smooth surface, non-tender with restricted mobility. On per speculum examination, it was 9 into 8 centimeter globular pink pale mass replacing posterior lip of cervix, and on per vaginal rectum examination, same abdominopelvic mass felt with an additional hard mass in the right fornix. Bilateral parametrium and rectal mucosa was free. In her initial evaluation, hemogram was advised, in which her complete blood count showed hemoglobin of 9.6 gram percent, total leukocyte count of 7,800, and platelet count of 3 lakh. She underwent panel of tumor markers, which was within normal limits. She also underwent co-testing for cervical cancer screening, which was negative, and she also had MRI done, which showed 3 well-defined hypointense lesion around 6.5 into 6 centimeter in right adnexa, 8.6 into 8.1 centimeter in the cervix, and 3.9 into 3.8 centimeter in the posterior uterine wall. And after this much evaluation, impression was cervical fibroid with an additional adnexal mass of the similar consistency, possibly broad ligament fibroid, was made. But it was the mass was very atypical in consistency, stony hard, fixed, with high vascularity on imaging and no areas of degeneration. And also in her routine peripheral smear examination, we found blast cells. And after this, evaluation proceeded in two directions. First, to confirm the diagnosis of leukemia, and second, to evaluate adnexal and cervical masses, that whether it is leiomyoma as it appeared, or metastatic disease of leukemia, or whether it is synchronous ovarian cancer. Now, I would like to invite my colleague from hemopathology, Dr. Preeti, to discuss the further slide.
Thank you, Dr. Pooja. Good afternoon, everyone. So, baseline diagnostic marrow we received in the month of Jan 2022. It was a slide for review from outside. With the clinical detail of known case of Graves' disease, underwent evaluation for menorrhagia from outside. Fish for translocation A21 was positive. Peripheral blood smear showed normocytic normochromic anemia with 9% blast. These large myeloblasts, they had eosinophilic granules and few of them showing or rod, which were long, slender with tapered end, which is very characteristic for translocation 821. Bone marrow aspirate slides were particulate and cellular. We can appreciate the blast here, which constitute around 11%. There was significant dysmyelopoiesis, as we can appreciate here the granulation abnormality in the eosinophil precursor. Occasional rods were also seen. Immunophenotyping was done from the peripheral blood. So after exclusion of the debris and doublets in the debris, there was a distinct CD34 positive population. We gated this population. This population was negative for T cell markers like CD7, cyto-CD3, surface CD3. It was negative for cytoplasmic CD79A. It showed aberrant expression for CD19. This blast population was positive for MPO. Positive for CD117, HLA-DR 1333, negative for 11B, and positive for CD38, while negative for CD6414, CD7, and this blast population was positive for CD56. So a diagnosis of acute myeloid leukemia with aberrant CD19 and CD56 expression was given.
Thank you, ma'am. After the confirmation of diagnosis of leukemia, next challenge for the team was whether to directly go for surgery to control abnormal uterine bleeding or whether to go for chemotherapy for the treatment of AML. As a disadvantage of performing surgery immediately was that chemotherapy would be delayed, and disadvantage of starting chemotherapy immediately would be subsequent myelosuppression, and surgery would not have been feasible. Meanwhile, we turn to our colleagues in radiology for further insight into the nature of the cervical and adnexal masses. And she was also given injection leuperolide for controlling her bleeding symptoms. I would like to invite Dr. Dipin to discuss our patient's imaging.
Good afternoon, everyone. So, the patient underwent MR pelvis outside AIIMS and the CD was provided for review. So, in the MR spots, in the T2 sagittal section, we can see a paracervical mass. In the posterior myometrium, there was another lesion which was heterogeneous in nature. And also in the right ovary, there was a homogeneous T2 hyperintense mass, which was having similar signal change characteristics like the paracervical mass. The left ovary was normal. In the diffusion restriction and ADC images, the right ovarian as well as the paracervical mass showed diffusion restriction, whereas the uterine mass didn't show any diffusion restriction. In the postGAD images, all these masses showed enhancement. So we did ultrasound for this patient, both transabdominal and transvaginal. So in the posterior myometrium, we were able to see a heteroechoic mass, and in the right ovary, there was a homogeneous hypoechoic mass with focal free fluid in the right adnexa. So this was the ovarian follicle. In the TVS, this was the paracervical mass. So, considering the imaging features, we gave a possibility. There were three lesions, one in the uterus, one in the right ovary, and a paracervical. So, the uterine lesion was typical of leiomyoma. The right ovarian and paracervical lesion was atypical for leiomyoma. So the differential first possibility was, considering the history of this patient, leukemic deposit in right ovary and paracervical location. The second possibility was these lesions to be an atypical leiomyoma. So we advise for a USD guided biopsy from right adnexal.
I would like to invite Dr. Trisha from Pathology Department to discuss ultrasound guided biopsies.
Thank you. Good afternoon, everyone. I am here to discuss the biopsy findings. So, the specimen we received was USG guided biopsy from right adnexal mass. As we can see in the first image, we received multiple cores of tissue showing immature cells. On the higher part, we can see those cells are having scant cytoplasm and this high NC ratio with dispersed chromatin. On immunohistochemistry, those cells are immunopositive for MPO and also for CD43. Both are of markers of myeloid lineage. So, based on the histomorphological and immunohistochemical findings, we gave the diagnosis of myeloid sarcoma or the granulocytic sarcoma.
Now, Dr. Nikhil will present the treatment part of our patient.
Good afternoon. So after diagnosing the patient with acute myeloid leukemia along with a myeloid sarcoma in the adnexa, we were planning for treatment. As per standard NCCN guidelines, we went ahead with the baseline evaluation, which includes a complete blood count with differentials, the IC profile, bone marrow examination along with flow cytometry, immunohistochemistry. The findings of this has already been discussed. Also, further cytogenetic analysis as well as a molecular testing by next generation sequencing as well as by PCR. And HLA typing was sent at baseline for the patient. And also a cardiac evaluation was done by an echocardiogram, which is normal. So after confirmation of diagnosis with the bone marrow examination as well as immunophenotyping, we went ahead with the risk stratification. Cytogenetics, as was already mentioned, patient had translocation 821 on conventional cytogenetics with a RUNX1, RUNX1T1 on reflex PCR. The myeloid NGS panel was sent, which was normal. So based on this, patient was diagnosed with acute myeloid leukemia, favorable risk as she had a translocation 821. The baseline workup was done and there was no hepatic renal dysfunction, and the baseline cardiac evaluation as well as the CT chest done for evaluation of infection was normal. Now coming to the management of this patient, we went along the lines of standard chemotherapy and started the patient on 3+7 induction, which basically includes 3 days of daunorubicin at 60 milligram per meter square and continuous cytarabine infusion at 100 milligram per meter square per day for 7 days. Post first cycle of induction, we did a bone marrow assessment on day 28, which still showed 6.2% blasts with a bone marrow cellularity of 70 to 80%. So the bone marrow was not in morphological remission, and we went ahead with a second induction. A second 3+7 induction was administered. Following the second induction, the end of induction bone marrow was in morphological remission with less than 5% blast, and flow cytometry for MRD assessment was negative. However, the molecular MRD by translocation 821 was sent, and this was still positive at 0.069 percentage. However, since the patient was in morphological remission, we went ahead with consolidation. Patient received 3 cycles of consolidation with high dose cytarabine. The dose that was given was 3 gram per meter square twice daily for 3 consecutive days. Following 3 cycles of consolidation, we reassessed the patient for response with a bone marrow examination, which was in remission. And this time, the MRD assessment, both by flow cytometry as well as molecular MRD by PCR for translocation 821, both came out to be negative. Since the patient had a right adnexal mass, we went ahead and did a follow-up MRI also to assess the status of myeloid sarcoma. My colleague would be discussing the same.
After chemotherapy, patient attained complete remission and follow-up MRI after 8 months revealed significant, almost 80% reduction in size of right ovarian mass with complete resolution of paracervical mass and no interval change in uterine leiomyoma. But still, on PET-CT, mildly metabolically active soft tissue lesion in right adnexa around 3 into 4.2 centimeter was there, and hence she underwent salvage abdominal hysterectomy with bilateral salpingo-oophorectomy. On histopathology, there was no residual tumor, and at present, she is disease-free since 5 months. Now, I would like to invite Dr. Saroj to discuss review on this rare case.
Thank you, Pooja. Now, gynecologists remain the first point of contact with female patients, and hence we come across a wide range of clinical challenges. In women with common gynecological symptoms such as abdominal mass or abnormal uterine bleeding, a differential diagnosis of a hematological malignancy is rarely considered, and hence there are often diagnostic delays which affect the prognosis of these rapidly progressively illnesses, especially when there is no past history or any simultaneously hematological manifestations. Abnormal uterine bleeding affects from 15 to 30% of women of the reproductive age. It can be caused by structural uterine pathologies or non-uterine causes, which can be ovulatory dysfunctions, disorders of hemostasis, or external medications. However, in 3.6 in 3 per 1,000 women with with abnormal uterine bleeding, they are often the first manifestation of a hematological malignancy. Myeloid sarcomas are an extramedullary solid tumor of immature myeloid cells. They were first reported in 1823 by Burns, who labeled this mass a chloroma because of the green color characteristically produced by the myeloid peroxidase enzyme. It was in the early 1900s that Dock and Wharton reported this association with acute leukemia. It was later labeled granulocytic sarcoma by Rappaport in 1966. And finally, in 2016, the World Health Organization defined the mass as a myeloid sarcoma. It is seen in 2.5 to 9% of patients with acute myeloid leukemia and is hence a rather rare entity. It can occur in addition with AML. It can also occur with myelodysplastic syndromes. It can occur simultaneously with AML. It can occur after the onset of AML, and in a rare percentage, in around 25%, it can antecedent the presence of blasts in blood and bone marrow, a phenomenon termed as isolated myeloid sarcoma. The median age for this disease is 56 years, and it has a slight male predominance. Now, in a review of more than 10,000 cases of AML, an incidence of 0.8% of extramedullary myeloid sarcoma was reported. This myeloid sarcoma was found to affect almost every organ in the body. There were 11 primary sites defined, of which the most common was connective and soft tissue, followed by the skin and breast, and then the digestive system. Reproductive tract is a rather rare site of involvement of myeloid sarcoma. However, it was found out that the site of involvement for this disease was a very significant prognostic factor, with reproductive and digestive organs lending to a good prognosis of more than 30 months. Involvement of the head and neck, breast, urological tract, or the retroperitoneum conferring an intermediate prognosis of 15 to 30 months, and involving the skin, skin connective tissue, lymphatic, cardiac, or bones and joints, offering a poor prognosis of less than 15 months. As mentioned, myeloid sarcoma of the female genital tract is a rare entity. Current existing literature occurs in the form of case reports, of which we were able to identify 112, and a small case series. We analyzed these 112 case reports available to us in the literature, and we were able to determine that the cervix was the most common site of involvement, almost 40%, followed with the ovaries, followed with vulvar and vaginal disease, and lastly the uterus. In 10% of population, it was found myeloid sarcoma was found to affect multiple sites in the genital tract, as was seen in our patient. On further reviewing these cases, the case reports available in literature, we were able to determine that the majority of patients presented with abnormal uterine bleeding and other non-specific gynecological complaints, such as abdominal pain, discharge per vaginum, or the presence of a vulvar or vaginal mass. In only 15% of this population was there a preceding history of a myeloid neoplasm. Although case reports favor towards the unusual, 60%, almost 70% of the case reports talked about isolated myeloid sarcoma. And in 70%, a preoperative diagnosis was established prior to commencing therapy. Our findings were mimicked by a literature review of 55 cases of Chinese literature. And they also found that the cervix was the common site of disease, 40%, followed by the ovary, vulva, uterine body, and vagina. It was determined that myeloid sarcoma arising in the ovaries had a slightly earlier age of onset, and that AUB was the most common presenting symptom. In women with with an isolated myeloid sarcoma, the appearance of a systemic leukemic disease had a median interval of around 5.5 months. All these case reports available to us had common challenges in the diagnosis of myeloid sarcoma. First, that it is an infrequent disease, and hence there was often a low clinical suspicion. Secondly, that they had a diverse clinical presentation with non-specific symptoms, and there was often a delayed diagnosis. Although 70% of patients had a established diagnosis prior to the onset of any definitive therapy, these were mainly seen when there was a myeloid sarcoma involving the cervix, vulva, or vagina, which are often areas which are easily amenable to biopsy and are habitually biopsied prior to starting any therapy. In myeloid sarcoma involving the ovary, only 40% were biopsied prior to initiating therapy, which is to be accepted, as adnexal masses are often not biopsied to avoid upstaging tumors prior to starting definitive therapy. Even in those in which histopathological diagnosis was possible either via biopsy or by surgical resection of the mass, there is a misdiagnosis rate of 25 to 40%, which is now decreasing in the era of immunohistochemistry. A case report well illustrates this pathological diagnostic dilemma by a 51-year-old patient who had been diagnosed with carcinoma breast and had been operated, followed by chemotherapy. 2 years later, she had presented with a left ovarian mass and CT findings suggestive of a peritoneal carcinomatosis. She was diagnosed with carcinoma ovary, and she had undergone an optimal cytoreductive surgery. The histopathology of the ovarian specimens resected showed immature tumor cells which were focally positive for CD68 and were diffusely positive for myeloperoxidase, CD34 and CD43, and hence a diagnosis of myeloid sarcoma was established. Following which the treating physicians reviewed the breast specimen excised, and that they found that they had a similar histology and a similar immunohistochemical profile, and hence that was likely to be a myeloid sarcoma as well. Furthermore, peripheral blood smear confirmed the presence of blasts with this patient, and hence she was finally diagnosed after a period of 2 years with myeloid sarcoma with active AML. Unfortunately, the patient expired before a bone marrow biopsy was possible and before any definitive chemotherapy was possible. Hence, it is imperative that a granulocytic sarcoma should be considered in the differential diagnosis of a poorly differentiated neoplasm, especially when the histological features suggestive of a large cell lymphoma. This is also a great mimicker, and it can resemble lymphomas, epithelioid sarcomas, undifferentiated or metastatic carcinomas. Well-differentiated myeloblasts can resemble benign inflammatory lesions, and in ovarian tumors, they can resemble granulosa or germ cell tumors of the ovary. Hence, as was necessary in our case, a multidisciplinary panel is often necessary to establish a diagnosis. The gynecologist who first receives the patient, the radiologist to which a clinical suspicion must be communicated, a pathologist who must again have a clinical suspicion to diagnose this tumor, hematocytologist and hemato-oncologist, and for further management of therapy. I would like to briefly share our experience with 2 other cases who presented with benign gynecological symptoms but were now diagnosed to have hemopoietic disorders. The first 31-year-old present. Acha. Yes. Okay, so I will skip this. And I will just ask our my hematology colleague to just briefly describe the treatment of AML.
I'll quickly go through the classification of myeloid sarcoma. Myeloid sarcoma with concurrent AML, around 3 to 10% of AML patients can have a concurrent myeloid sarcoma. The second, extramedullary relapse of AML. This includes a post bone marrow transplant setting also. Even other diseases like MPN or CMML can present with myeloid sarcoma. Isolated myeloid sarcoma is quite rare. These patients present with a normal bone marrow examination blood film and there is no myeloid neoplasia. Around 2 in 100,000 cases have been reported in literature. I would not go into the details of genetic profile, but the most common cytogenetic abnormality which is associated is translocation 821, as was in our case, and the most common molecular abnormality is NPM1 mutation. No large trials have reported the prognosis. The questions that come to our mind, should all myeloid sarcomas be treated? Yes, because almost 100% of the cases progress to AML within 3 to 10 months, as has been reported in literature. And the treatment given for myeloid sarcoma is same as that of AML. The only difference being if patient has any compressive symptoms, additional surgery or radiotherapy may be necessary. Age, tumor location, presentation does not make any impact on the prognosis. And these patients who have undergone transplant have outcomes similar to that of AML patients without myeloid sarcoma. 5-year overall survival rates of around 48% has been reported, indicating that there is no difference in overall survival because of the presence of a myeloid sarcoma. However, isolated myeloid sarcoma patients have reported to have a slightly better prognosis compared to AML. And as my colleague has already mentioned, myeloid sarcoma involving pelvis, genitourinary organs, eyes, gonads, and GI tract have a comparatively better prognosis. Isolated myeloid sarcoma of soft tissue sides, hematopoietic system is comparatively poor with an inferior 6-month survival. As I mentioned already, all patients should be treated and the chemotherapeutic regimens are similar to what is used for AML. Surgical intervention or radiotherapy is indicated in patients, especially if there is a mass effect and an urgent debulking is indicated. Regarding indications for transplant, there is no clear-cut data regarding transplant in myeloid sarcoma, but for all indications with related to AML, they should be transplanted. In isolated myeloid sarcoma, there are few studies which have shown that taking them up for upfront transplant might be beneficial, and the outcomes at 5 years were similar to that in patients with AML as with patients with a myeloid sarcoma. I would like
We'd like to invite any questions. So she had a large cervical mass and she was actively bleeding from that cervical mass. She's a very well educated lady, ma'am, with always very regular menstrual bleeding. So since the first episode of bleeding, she first sought contact. However, she visited multiple physicians. So by the time she presented to us, it was a bit late.
She didn't have one episode, ma'am. She started 3 months ago, and thereafter, for next 3 months, she can continue to bleed off and on. Even during treatment, we had a lot of challenges while bleeding, and every time we would go running to Dr. Nina and ask her, "Ma'am, kya kare? Bleed kar rahi hai." Then ma'am would say, "Okay, let's." Then ma'am, after discussing with ma'am, she decided to give her injection Lupride, and then we gave. Meena, ma'am, final opinion from you, ma'am.
I would not breach confidentiality. She is a relative of one of our faculty colleagues. And I would just like to say that COVID was a bad time. We didn't have theater, but once we, sending somebody for a routine peripheral smear and learning its blast is, I think, an unusual, feel. And we did not have theaters. But yes, while the OT closed and we were giving chemotherapy for this patient, we were at least literally walking a tightrope, to on the fence because she bleeds. And then, when they get chemotherapy, they further bleed because we know that. So certainly, I would say it was definitely a team management, but then what we could have in hand was just Lupride that came to our rescue. Yes, interesting. She had masses, yet she did not bleed, which is very unusual. So perhaps, that bleeding was actually brought her to a gynecologist. Otherwise, who knows? So many times fibroids are asymptomatic, but actually it was not a fibroid. It was this thing. Yeah, Sandeep. Nice. And And I just would give a tip to my postgraduate and senior residents. You will rarely get to do a lot of pervaginal examination in patients with cervical fibroids. They're so typical. But what was so atypical was not that the size, fixed mass, and stony hard. I've never done a PV like that. I'm sure the postgraduates who are with us would really recall this was an unusual finding. So obviously we were understanding it's not a norm of a cervical fibroid, something beyond the cervical fibroid. So no more questions? Yeah, unusual. Thank you very much.